you about the non-tuberculous mycobacteria. Because we are mainly knowing about the tuberculosis, which is caused by Mycobacterium tuberculosis complex, with which complex is made up of more than 4 bacteria. But the Mycobacterium mainly is caused by Mycobacterium and leprosy, which is caused by Mycobacterium. But we are knowing this about the mycobacteriosis, which is caused by non-tuberculous mycobacteria. So infection produced by non-tuberculous mycobacteria is not comes under the tuberculosis, but the infection is caused mycobacteriosis. These mycobacteria name we know by various names, but American Thoracic Society and Infectious Disease Society of America endorsed this name non-tuberculous mycobacteria. These mycobacteria are prevalent in, these are mainly septophagic mycobacteria present in the environment, and they can cause any type of infection. This is a very old case, not found in this institute, but just to give you a brief history how the NPM can come to your part of cookery. A female 38 year undergone hysterectomy in a private hospital for fibroid uterus. This private part is very important because most of the cases where the non-tuberculous mycobacteria we have isolated were operated in the private hospital. Number second, developed post-operative infections that was aspirated and treated with antibiotics but reaccumulated again after 2 months. Incision and cleavage was done, sample sent for histopathological examination, but what was the histopathological examination? The diagnosis we didn't know. Then overall diagnosis which was mentioned on the treatment card was non-healing tuberculous sinus of anterior abdominal wall. Patient was given ATT for 9 months, and then after 2 months post-ATT, she again developed same complaint, and for that she received antibiotic for 10 to 15 days. But after that she again developed the same type of complaints. With this past history, patient presented to SCPGIMS with pollen discharging abscesses from stone with small nodular swelling in intra-umbilical region. Excised from the specimen received validation for culture sensitivity and also for mycobacterial culture sensitivity. The histopathology report which was noted from the HIS system showed that the subcutaneous suppurating necrotizing granulomatous inflammation suggests tuberculosis. This is the case which was presented. This patient was actually referred to General Hospital of Sanjay Gandhi, but ultimately this patient was then again referred to gastrosurgery department. Now, in routine bacterial culture, it shows Staphylococcus aureus, but we didn't care for this Staphylococcus aureus because the patient has already taken treatment so many times for routine this bacteria. Mycobacteriology, the smear was positive for acid phosphorus, and the culture of LJ shows growth after 4 days. Routinely, what we are getting for the tuberculosis, the growth is not in less than 1 month of duration. So in these cases, the bacteria can grow very rapidly. Then culture smear was also positive for acid phosphorus, and on biochemical identification, the isolate was Mycobacterium autism. This shows the culture smear ARP, and the another shows the LJ colonies on the culture. This is the colonies on the LJ media. If you see and you don't know about the duration of the incubation, you are really confused with the Mycobacterium tuberculosis because these colonies are not separated from the Mycobacterium tuberculosis. But we were knowing that this growth is very rapid growth and it appear within 4 days. And because these bacteria can also grow on the bladder duct and the mitochondria also. Now just to rule out whether this is not the mycobacterium tuberculosis, the PCR was done and this shows that the molecular, this is the row for the molecular marker, and H37RB control, which is the control for mycobacterium tuberculosis complex, and this is number 2, this shows the band, and third and fourth is the two cases which we put together, and this is the mycobacterium tuberculosis complex isolate from the laboratory. So they are band into these two samples, and it means the isolate was not mycobacterium tuberculosis complex. Now the antimicrobial susceptibility testing was done because this was the mycobacteria. So antibacterial susceptibility was done by two methods. One is the disk diffusion method, and second is this is the commercial method in which the ELISA plate are already seeded with the antimicrobials with different concentration. So this is the MIC method. And these are the different antibiotics and different antimicrobial with different concentration in the ELISA plate. Now this isolate was sensitive to latanosomic, erythromycin and amikacin, and resistant to other antimicrobials. So verification was put on erythromycin and naloxone for 3 months, and the follow-up was done in 6 months. So after the 6 months, there was no utilization system. So this was a brief history of a patient who presented with non-tuberculous mycobacteria. There are other cases where we isolated non-tuberculous mycobacteria. Somehow same type of the illness, same type of the presentation. These are the few. Like this is the post-surgical, is after the laparoscopic polycystic pain, the patient developed this wound infection. This is also the patient developed the wound infection after the laparoscopic polycystic, and this is after the post-injury. The patient developed wound infections by the non-tuberculous mycobacteria and referred from their room. And this patient was a very different case which presented to skin and baby department as and who took treatment for APP and for also steroid, but he didn't respond to that treatment. And after that, the growth was isolated from different side, and it showed the non-tuberculous mycobacterial infection. So this was about the presentation of the brief case. Now Dr. Saroj Das will tell about what is the epidemiology and incidence of this disease, and what is about the non-tuberculous mycobacteria in general.
Now I am going to present about the incidence and prevalence of NTM infection in case of Indian scenario, also internationally, and also the laboratory diagnosis of NTM infection and its prevention and treatment. NTM infection occurs worldwide. It occurs mostly in developed countries rather than the developing countries. But as a class, it occurs both in developing country and developed country. And these are the isolation rate of NTM infection in Indian study. One study by that is from SGPGI Lucknow. The isolation rate of NTM was about 7%, out of which the pulmonary infection constituted the major part, that is about 2%, followed by soft tissue and post-surgical breathing infection, that is about 1.85%, and deep-seated infection, that is 0.49%, followed by disseminated infection. Similarly, a study from CMC Bureau showed 3.9% of isolation rate of NTM infection. Similarly, a study from Amritsar showed 10.6% infection. Many of the literature says that the incidence rate of non-tuberculous mycobacterial infection in India ranges from 0.1% to 10%. And this study, the upper study from Agra, where the isolation rate of NTM was about 0.4%, that is by pulmonary infection, show the ranges of NTM infection. The isolation rate of NTM infection ranges from 0.1% to 10% according to different infections. Now come to some international study. It has been seen that the NTM infection isolation rate has been much more increased in different international studies rather than the developing countries. Similarly, there is a study from Greece in which the isolation rate of NTM was about 18.9%, which is based on the pulmonary symptoms. Similarly, a study from USA, there was incidence rate of 11%, and there is a study from Taiwan which showed about 16.55% of isolation rate of NTM. Similarly, a recent study from USA has shown about 35.3% of incidence of pulmonary infection by NTM, which I will not mention the study. Now coming to the spectrum of the disease by NTM. NTM infection occurs both in immunocompromised patient and immunocompetent patient. But the dissemination infection is much more common in immunocompromised patient rather than the immunocompetent patient. Different organ system can be affected by non-tuberculous mycobacteria. For example, it can cause pulmonary disease, lymphadenitis, cutaneous disease, disseminated disease in HIV or AIDS patient or immunocompromised patient. It also can cause infection of bone, joints, etc. It also cause wound infection, sepsis, and catheter-related bacteria along with Crohn's disease. Pulmonary disease is most commonly caused in elderly patients, and the most important the classical mycobacterium NTM species that causes pulmonary disease are Mycobacterium avium complex, followed by Mycobacterium kansasi and Mycobacterium abscessus. And it generally occurs in the elderly age group. Similarly, lymphadenitis is caused in children age group from 1 to 5 years, and the most common species that has been isolated from lymphadenitis is Mycobacterium avium complex, followed by Mycobacterium staphylococcus and Mycobacterium amoebius. Similarly, cutaneous infection is most commonly caused by Mycobacterium venereum, followed by Mycobacterium fortuitum and Mycobacterium pneumoniae. There is one species of non-tuberculous mycobacteria, that is Mycobacterium ulceraris, which causes a buruli ulcer. And buruli ulcer is nothing but it is some nodular pattern of skin infection that occurs in elderly age groups. Similarly, disseminated infection also caused by NTM species, mostly in the HIV patient. When the CD4 count is less than 50 per cubic mm of blood, disseminated infection generally is caused. And the most common species that has been isolated from disseminated disease is Mycobacterium avium complex, that is about 95% cases, followed by Mycobacterium kansasi and Mycobacterium pneumoniae. Now coming to the infection of bone, joints and etc. And the most common species is again Mycobacterium avium complex, followed by Mycobacterium zingae and Mycobacterium fortuitum and Mycobacterium kansasi. Similarly, wound infection is most commonly caused by a rapid growing Mycobacterium species, rapid growing NTM species, that is Mycobacterium fortuitum, Mycobacterium pneumoniae and abscess. Mycobacterium fortuitum, pneumoniae and abscess, these are termed as rapid growing Mycobacterium species that causes wound infection along with sepsis. Nowadays, some NTM species also causes some nosocomial infection, that is hospital-acquired infection, that is Mycobacterium mucogenicum, which is one of the most common causes of hospital-acquired infection that causes infection in catheterization. Similarly, Mycobacterium paratuberculosis is a very important pathogen that causes there is a etiological agent of Crohn's disease. NTM species has been known since a long time, and Reunion was the scientist who first classified NTMs into 150 species, that is in 1954. So till today, about more than 150 NTM species has been known, and the different names of NTM species in mycobacteria other than tuberculosis are not, or atypical mycobacteria, or environmental mycobacteria, or opportunistic mycobacteria, and they have variable pathogenicity and geographic location. About 40% of these 150 NTM species cause disease in humans. So the reservoir of NTM infection is very vast, and NTM infection occurs ubiquitously. It has been isolated from water, soil, food, animals. But one of the peculiar feature is that it does not spread from person to person. Where Mycobacterium tuberculosis spread from person to person, and it is relatively resistant to pollination and ozonization. The modes of transmission is maybe by inhalation, ingestion, or direct inoculation. In fact, ingestion account for about 80% of infection, route of infection in HIV patients. Outbreak in pseudo-outbreak still occur in hospital. It also occurs in HIV dialysis patients, which I have already mentioned. Now the incidence of MTM is increasing day by day. It is due to the following factors. First is increasing living standard, showering instead of bathing, sensitive laboratory isolation technique, and the source of infection is diverse. It may be from water, soil, house dust, distilled water, hot water system. In case of hospital setting, it can be also caused by bronchoscope, peritoneal dialysis. There is also impact factor by climatic changes. Now coming to the trends of NTM infection. NTM before AIDS epidemic, it was primarily in pulmonary with or without involvement of cervical lymph nodes. After AIDS epidemic, it is usually disseminated infection following different organ systems. The current trend is high in developed world like United States and Europe, low in developing countries like India. The trend is reversed from mycobacterial tuberculosis species. Now coming to some predisposing factors which causes increased incidence of NTM infection. Any alteration of local or systemic immunity, chronic obstructive pulmonary disease, emphysema, pneumococcosis, bronchiectasis, cystic fibrosis, and patient with previous gastrectomy and chronic arthritis. These are the predisposing factors which causes increased incidence of NTM infection. Now coming to the classification of NTM, the Renal first classified in 1959 according to the growth rate, colony characteristic, and pigment production. According to growth of the solid media like enzyme media, it can be divided into two types: slow growing NTM and rapid growing NTM. Slow growing NTM are those NTM species which takes more than 7 days to grow on solid media, and rapid growing NTM are those species which takes less than 7 days to grow on solid media. According to pigment production, again they can be classified into group 1, group 2, group 3, and group 4. Group 1 is photochromogens. That means these are the NTM species which produce pigment in the light. Group 2 is photochromogen. So these are the NTM species which produce pigment both in dark and light. And group 3 are non-pigmented. These are not producing pigment even in the presence of light. And rapid growth Now come to some common features between NTM species and MTBC species, and some different features. When we are talking about the common features, they are most common by acid fastness, genetic directness, overlapping disease spectrum, and similar histological findings. The difference lies in public health implication, laboratory processing and treatment, virulence, and colonization. Both NTM species and MTBC species are genetically heterogeneous, which is shown by the sequencing of 16S ribosomal RNA, and they have nearly similar clinical signs and symptoms and similar histological findings in case of MTM and MTBC. The laboratory processing and treatment of MTM and MTBC is quite different. For example, when we receive a sample for mycobacterial tuberculosis, we decontaminate the sample with sodium hydroxide. The concentration of sodium hydroxide used for decontamination of MTM species is very less as compared to MTBC species. And MTM species are less virulent as compared to the mycobacterial tuberculosis complex, and they also act as colonizer than the MTBC complex. Now coming to the clues for diagnosis of NTM infection, what are the different points which favors in the diagnosis of NTM infection? Any chronic infection or pyrexia of unknown origin or localized clinical disease like abscess, ulcer, nodules or infiltrates which is not responding to antibiotics. Hereditary or nodular pulmonary chest opacity is not responding to ATP. But out of this, the most characteristic feature is the presence of thin walled cavity with lesser parenchyma infiltrate described as the most characteristic feature for diagnosis of NTM infection. Similarly, non-healing skin and soft tissue infection is also one of the important things for diagnosis of NTM infection. History of exposure to water sources, animals, wounds or catheterization is also important for the diagnosis of NTM infection. Now coming to the diagnosis of NTM infection, appropriate sampling and strict laboratory practice should be done to avoid the contamination, because NTM is ubiquitous, it may contaminate the culture specimen. And and correct identification of the positive microbacteria and their sensitivity profile is crucial. According to the American Thoracic Guideline or IPSA guideline, the diagnostic criteria is there. At least 2 expectorant sputum or at least 1 bronchial was or lavage should be positive by culture, or the transbronchial or non-biopsy showing presence of granulomatous infection or AFB with 1 or more sputum or bronchial was should be cultured. These are the criteria which is called ATS criteria, IPSA criteria. Now coming to what is the specimen for diagnosis of NK infection, it may be pulmonary specimen. Out of in pulmonary specimen, at least 2 sputum or 3 sputum, along with bath or tissue biopsy is taken as the gold standard for the diagnosis. Similarly, the specimen directly obtained from the region and organ concerned are much more appropriate, along with the granulation tissue. Similarly, aspirate of body fluids, abscess and tissue are generally recommended, but swab should not be recommended. In case of disseminated infection, blood and bone marrow aspirate are much more convenient. A single blood culture provides about 90% of sensitivity. A double blood culture provides about 99% of sensitivity in case of NK infection. Now coming to the laboratory diagnosis of NK infection, it can be diagnosed by simple microscopy. Simple microscopy is rapid and economical, and the different staining method that we are using is fluorochrome method or gene Nielsen staining. Fluorochrome staining is very rapid and is very sensitive, but after the staining by fluorochrome stain, it also be stained with gene Nielsen staining in order to increase the specificity of the staining method. And during the staining method, we must use weak decolorizer for rapid growing microbacteria. It can be cultured both in solid media and liquid media. The different solid media that can be used for the diagnosis of NK infection are MJ media, middle group 7S10, 7S11 media. And in case of liquid media, the middle group 7S9 and 7S12 media. Similarly, we can also perform SPLC, high performance liquid chromatography, in order to analyze the mycolic acid content of the entrance species. And in fact, this is one of the most important diagnostic methods for diagnosis of NK infection. Similarly, molecular methods can also be used. Out of these, the 3 important molecular techniques that are generally used in everywhere for diagnosis of NK infection are gene probes. Gene probes, amplification methods like PCR and real-time PCR, and line probe assays. Similarly, for epidemiological purpose, we can also do sequencing in order to specify the epidemiology. Now, when we get a positive culture in our laboratory, whether it may be contamination, or it may be colonization, or it may be disease. So, for this, we have a guideline, the IPSA guideline, which are already put. The minimum evaluation should include is chest radiograph, HRCT, exclusion of other disease, and at least 3 sputum or respiratory samples for AFB. A single sputum sample is not sufficient. When there is a presence of single sputum sample which is culture positive along with field colony, it is generally recognized as colonization rather than the disease position. Now coming to the management. Management can be prophylactic, may be surgical, or may be medical. In the prophylaxis, generally in United States, prophylaxis has been given by rifabutin. Rifabutin causes decrease in signs and symptoms in HIV patients, so it is used in United States only. And the surgical treatment, it is done in case of cervical lymphadenitis, when there is presence of pus in left tissue and infection due to mycobacterium falciparum and tuberculosis. And the medical treatment should be based on background information about sensitivity profiles. The treatment protocol of slow growing NTM is quite different from rapid growing NTM. In the slow growing NTM, first line antitubercular drug along with amikacin, ciprofloxacin, erythromycin, retifoxacin, moxifloxacin, linezolid, minocycline, and sulfamethoxam is used. In case of rapid growing NTM, no response to, they are not responsive to first line antitubercular drug. So in this case, amikacin, augmentin, ciprofloxacin, immunoglobulin, doxycycline, chloroquinone, sulfonamide or dimethyl sulfamethoxam, erythromycin, linezolid, and tobramycin, and minocycline are generally used. Now coming to some specific treatment protocols. For slow growing NTM species, drugs that are more effective against microbial avian complex are a combination therapy of erythromycin plus rifampicin plus rifampicin. Twice weekly into 18 months is sufficient. And in case of HIV patient, rifampicin should be substituted with rifampicin. Drugs that are more effective against mycobacterium canceraceae, isoniazid, rifampicin and ethambutol, that is given from 18 to 24 months, and rifampicin or clarithromycin should be substituted in case of HIV. Clarithromycin is one antibody that is highly active against mycobacterium meningium, mycobacterium pneumophilum, Xenopi, abscession, pneumonia, and most transmissible mycobacterium pneumonia. Now coming to the drugs for rapid cures, in case of mycobacterium abscesses, which is a rapid cures, the treatment protocol is combination therapy, that is amikacin, ciprofloxacin plus clarithromycin 1 month along with surgical intervention. For other mycobacterial species, generally antimicrobial sensitivity testing is required. Clarithromycin and amikacin causes is very much active in case of 90% of mycobacterium substitutum and most mycobacterium rheumatics. Ciprofloxacin is active against 80% of mycobacterium abscesses and mycobacterium substitutum. Doxycycline is effective in case of 50% of mycobacterium substitutum, and imipenem is effective in case of 100% of mycobacterium substitution and 7% of mycobacterium chemistries. Now this is the paper from Lancet 2008. This shows the important NGO species along with their diagnosis, treatment and prognosis. The most important diagnostic method which I have already told is aptitude method, line growth assay and high performance synthetic chromatography. These are generally used for all the NGO species except two species. For example, for mycobacterial abscesses and mycobacterium semi, generally line growth assay along with gene sequences is required. And the treatment protocol is same. Everywhere it is about 18 months except in case of mycobacterium abscesses where it is about 1 month along with surgical injection. And the outcome is generally good in case of mycobacterium canceraceae species, and for all other NTM species generally it is poor or poor. Amplification of a PCR, whenever we are getting a sample, we just extract the nucleic acid and this nucleic acid is get amplified by PCR. So now you are using this amplified product PCR and you are getting reverse hybridization with a solid support DNA probes. So now the target sequence is complementary sequence which get attached to this DNA probes. And after that we are using some conjugates and substrate which gives a color reaction. By seeing this color reaction by naked eye, you can identify that this is a positive or negative. So yes, so this is the combination of amplification plus reverse hybridization.
You can say these are gram positive bacteria, but the gram staining is not done properly.
Are they sensitive to normal gram positive drugs with an active gram?
They are sensitive, most of the non-tuberculous microbacteria which are rapid growing microbacteria. They are mostly sensitive.
Besides this one,
The rapid growing microbacteria, they are not sensitive to rifampicin and iron. So mostly the protein and the microbials are used. And for slow growing microbacteria, mainly the rifampicin, we can recall amplified. But ionic chain processes are very hard. Only except the mycobacterium canceraceae, where we deal with ionic. These atypical mycobacteria they are now classified only as mycobacteria. Slow going are rapid.
Then they start erythromycin and laboratory for atypical and response, but before that is for treatment.
But better you should go for the ASP